Thank you very much for the invitation. So today's topic is the fully guided partial extraction therapy as a standard of the 21st century. So it's a topic which is going around my presentation since few years. I try to do every partial extraction therapy case guided. Thanks to Megagen, I can have my own kit to do it now. And I want to show you the very interesting case, which is very challenging actually. So starting with the socket shield or partial extraction therapy, I'm a huge fan of it, especially in aesthetic zone. I think it's nowadays is a standard to achieve amazing aesthetic result. So today's case is a double guide system with R2 gates. So I use an R2 gate as a base. I make a project of two guides. One is for the implant placement and another one is for the preparing the shield. So my case is the tooth number 13. There is extraction of the endodontic treatment canine, very long teeth. Here I plan 3.8 core, 15 millimeters enriched implant to achieve the most stability. And for the partial extraction therapy, I use even longer drills. By coming to the background of the planning in R2 gate, especially this kind of difficult aesthetic zone cases, we have a classification of sagittal root position in relation to the anterior maxilla. In the case of the implant placement, so we have a classification, what kind of connection between bone and the teeth we have. In this case, is the class 1, is from Jeff Kahn. And the correlation to this study is a study from our beloved Howard Gluckman, who add to this classification how we have to make a planning, where we have to drill, how we have to go with the bone. So according to both these literature cases, we can make a planning according to the good bone position and of course the prosthetic. And coming to the most interesting part is to creating the guide for the partial extraction therapy. In this case, we use 18 millimeters drill. I mix in this case a guided kit and Howard Gluckman kit, and now my own kit for the partial extraction therapy. So in the case of this long tooth, I have to remember to hit the apex, to remove all of the gutta percha. And what is very, very interesting, if you will see on the left side of the case, where you have the axis of the root, it's completely different than the position of the implants. So that's why we have to use two guide system, because in the many cases in aesthetic zone, there will be completely different positions from the implant and from the partial extraction therapy guided. So this is how it looks in the mouth. The patient is a 34 years old gentleman with no allergies, no general diseases, general healthy. And what we see here, it's very big root, very long root. And if we go with the classic approach with the extraction and with the grafting and soft tissue grafting, the most crucial thing will be the extraction of the teeth. It was 22 millimeters root. So as you know, and very thin buccal bone, it's very, very difficult to do it and not to break the buccal bone. So in these cases, the PET should be considered as the first step that is much more predictable in the case of the surgery. So here we place our first guide, which is connected to the partial extraction technique. We drill through the guide. I always drill up to 3.3 millimeters drill, that I'm sure that I remove the apex and I make my PET thinner. I want to make it around 1.5 to 2 millimeters. So what is here very necessary to mention, that in the extraction socket like this, that is in aesthetic zone, and if we can avoid doing a flap to manage our post-extraction socket, it's much better. In this studies from Shu and Salamas, they say that's the best way is to graft, the socket, to use the temporary, and to not elevate the flap. So that's how we do it here. So we prepare temporary, we will graft the gap, and we will not raise the flap. So as you see here, we have prepared the drills for the root. We remove the gutta percha, and now is the most crucial thing is to separate the root and remove the palatal portion. So as you see here in the pictures, we have very important things that palatal root portion is removed. And what I love to see is that you don't have the apex, which is very crucial, especially if you will take into consideration that the root is above 20 millimeters, it's almost impossible to remove it free-handed. It's very difficult. It's almost a blind surgery. So that's why the guide is so necessary. So this is how it looks after removing. We know we have to prepare the shield. We use, of course, the Howard Gluckman kit, which is the best tool which you need to do the partial extraction therapy. So as you see here, it's separated. We have to go at least at the bone level and then make S shape from the root. We place here 4.5 implant in diameter with the core 3.8, 15 millimeters to get a good primary stability, the high ISQ value due to the big bone implant contact. So we put out the second guide and we make a drilling and we place the implant. So as you can see here, we have 3D guided implant position, which was planned before. We have space for the socket augmentation, which is necessary in these cases. And we see how we prepare the shield with the S shape and we go below the bone level. Of course, smart pack and ISQ in all of my cases is a standard procedure to be sure that we're doing a right decision in the case of the loading. 74, high ISQ value, and as we all know, everything above 70 in the case of the single units, we can load immediately. So we are on the safe side, we don't have to be worried. As you see here, we need to do the grafting, and the best way to graft around partial extraction therapy cases is the allogenic bone or autologous bone. In these cases, we use the allogenic bone, the very small particle, the smallest that we can get, 0.1 to 1.2 millimeters size. In this case, we use a temporary cylinder with the hex. Why with the hex? We have to remember that always the more anchorage which we have in the implant causes that is more stable. So the temporary work, so temporary crown, will be much more stable and there will be no micro movement. If there will be no micro movement, then we will have no bone loss at the time of the healing. So it's very necessary to think about it during the preparation of the temporary solution. So here is our temporary crown, which will leave for at least 3 months. We have CBCT, and what we see in the CBCT, we have the shield, which is at the bone level. We have grafted the side of the space between the partial, between the shield and the implant. A very necessary thing which we have to think about it and take into consideration is depth of our implant. In this case, we are following zero bone loss concept from Thomas Linkevicius, so we have to go at least 4 millimeters from the soft tissue. Here we go a bit deeper due to the size of the socket. If there is another very, very important thing why we grafted and why I'm very huge fan of the socket shield, because these are the studies which are talking about unplugged socket shield. So somebody left the part of the root, placed the implant. After that, they realized, look, we have the root, we have to remove the implant. And when they make a histopathology trials between the bone which is formated between implant and the root, they found that is perfectly fine bone. So that's what we want to achieve, is to have the sound bond around our implants. After many years of studies, you can know that we don't want to use the xenograft material because for the long period we'll have the bone loss and the periimplantitis will dramatically accelerate. In the case of here, we have the best possible thing, so we have sound autologous bone. 9 months later, the patient came because he's actually working abroad. Perfect soft tissue, perfect outcome from the aesthetic reason. There is huge papilla, very high papilla, so we achieve everything possible. So the good 3D position, we manage the grafting, everything. We started doing the scanning. Of course, with the digital approach, we make a scanning. And what I check here, it's I make some cuts from the first scan and I measure what is the width of the socket. And it came out as 8.977 millimeters. I did the same in the last scan when we take the impression, and it's almost the same after 9 months of the healing. So if I compare it in the day of the surgery and the 9 months later, we have a almost 0.2 millimeters difference. Of course, it can be occur some wrong calculation or some kind of miss of the software. But what I want to mention here, that after 9 months of healing, and in very difficult case, as we have the upper canine, which is a very big socket, we have minimal shrinkage of the soft tissue. So this is the reason why there is a high demand of this kind of procedure in aesthetic zone, that we can be sure that we want to lose a many bone, especially if we compare to the study which are from the team Atlanta, which I mentioned that we have to do the provisional and do the grafting. Here we do everything and more with the partial extraction therapy. And the same, there is another case of studies that shows there is a less shrinkage of soft tissue and bone comparing partial extraction therapy case and classic procedure with grafting and soft tissue. I've done many cases. Unfortunately, this case, I cannot show you the finish of the crown because the patient is working abroad and he will be next week in Poland and I will deliver him the final crown. But there are many cases which I done in the last years. I did around now 90 something cases of the partial extraction therapy. I done everything guided. And what is for me the most important thing in the whole concept, that we have very good aesthetics. We don't need many procedures, and there is a sound bone around implant. So we are very, very safe in the case of the long-term observation because we are minimalizing the risk of periimplantitis in the case of the xenograft materials, in the case of overgrowing the soft tissue. So in this case, and in many, many, many cases, of course, the technique as itself is very sensitive. That's why I think the guided solution for it will provide it to be more used in daily practice for more dentists, and the dentist can deliver the high aesthetic, very difficult treatment for the more patients. As me, the partial extraction technique should be considered really as a standard of the 21st century cases, especially in aesthetic zone. Thank you for your attention.